of Gold 2021. And then I'm going to take what for me are the 10 most important teaching slides from the Gold 2020. They have a teaching slides set that you'll hear about in a moment. And I picked out what I thought were the 10 best slides, or maybe I should say from my subjective perspective, the 10 most important, and go through those with you. The big change for Gold from Gold 2020, Gold 2021, is that they have a new chapter, and not surprisingly, that new chapter is all about COVID. So we'll go through that. That'll end the didactic, and hopefully we can have a few questions or comments, or maybe people pointing out things that I left out. And if you pay close attention, you'll see there's some important things left out. And then I would like to do a case presentation. And in this case, the presentation isn't about a specific patient. It's a case report about a rural network. And then finally, I'm going to throw out to our APHP RTs and sites the idea of doing a small chart review at our sites to check and see and to keep track how well we're doing at our sites of actually implementing and observing the Gold recommendations. Next slide, Mitra. But first, why should we use Gold? And I call them guidelines here. Why use Gold guidelines, or for that matter, why use any guidelines? And I gave some examples here. We have the ADA guidelines for diabetes care. We have the NIH guidelines, JNC 8, I think is the last time JNC was updated, for managing hypertension. American Heart Association has wonderful guidelines for chronic heart failure. NHLBI has guidelines for asthma, EPR3 guidelines, and they finally did update those in the last year. Next slide. And as you notice, all of these guidelines really relate to care of chronic disease. So why we have guidelines, and there's an important qualification about guidelines, because guidelines should be evidence-based. And so all the guidelines we're talking about today are evidence-based. In other words, the recommendations they're making are based on valid evidence of effectiveness. And so the reason we have guidelines relate to something called the triple aim. And the triple aim is known to most health services people and policy people, but maybe not to all clinical people. You probably heard of it. What the triple aim is it says that all efforts to improve or reform healthcare, and especially in our country, should aim to improve the experience of care. That's what's it like for you and me as an individual patient to go to the doctor or go to the hospital, that we have a better experience, improve the health of populations. So that's looking at whole groups of people doing better. For example, all people with COPD, having better outcomes. And then finally, to reduce the per capita cost of healthcare, that we are working more efficiently. That's why we have evidence-based guidelines and follow them. And I can say that it is true of the Gold report that they have a careful system for basing their recommendations on evidence, and you'll see examples of that in a minute. Next. Right now, there are 3 evidence-based COPD guidelines that exist. There's the Gold 2020 report, and now it's 2021. There are the NICE guidelines, which the National Institutes for Clinical Excellence, which is kind of the NIH of the National Health Service of the United Kingdom, Great Britain, Scotland, Ireland. And it's really important to keep an eye on those. And Dr. Alison Sela has been once a year doing a report about NICE, like I'm doing right now about Gold 2021. A year ago, ATS came out with clinical practice guideline for pharmacologic management of COPD, where they updated some of the recommendations on pharmacologic management. That's important. There's another guideline that comes from the Primary Care Respiratory Society in the UK, and I'll mention that a little bit later. Next. So here's an overview of the GOLD report. In a little history. GOLD, the Global Initiative on Obstructive Lung Disease, was established in 1998. They came out with their first guideline in 2001. They made major revisions, 2006, 2011, 2017, and perhaps because of the new chapter this year, we should say 2021. It's important to know that I said that GOLD comes in 4 flavors. There's the full report, which is 152 pages, which actually isn't that long. Then there's a pocket guide, which is 50 pages, which you can print off as a PDF. Some of you know that the COPD Foundation has a little trifold laminated card that you can put in your pocket, and that's a really good thing. And I wish there was a little trifold laminated card for GOLD, but to my knowledge, there isn't. Because pretty much not many people are going to read the full report. And by the way, if anybody here has read the full report, I would love you to put that in the chat and take credit. We'll tip our hat to you. I haven't, although doing this talk this year and last year, I read a whole lot more than I ever had before. And I found myself trying to read at least 1 or 2 chapters thoroughly and then look at the recommendations that begin at the beginning of each chapter. Then there's the teaching slide set. It has 52 slides. That's a really good resource for those of you who are in a situation where you're doing a presentation to something at your hospital or your health center or grand rounds. Right, Elizabeth. And then there's an app for GOLD. So you can download that app for your smartphone, and that's another way to have this handy. Something I think really important about GOLD is it's international. There may be other international guidelines. There are international guidelines, but this is one of the most important major chronic disease guidelines that I can think of that's based on an international consensus rather than simply a national one. And it's free, and that's a great advantage. Something to be aware of is that it is funded and therefore controlled by the Pharmaceutical Research and Manufacturers Association of America. And if you want to know why I think that's important, we can discuss that at some other time. Next slide. So now here's the overview. And I said, this is the overview of the report, last year's report, because it would look exactly the same this year, except a chapter 7 would have been added. So these categories, I mean, if you were going to write a book about how to take care of COPD, you'd have to think about how to divide it up and what would be your main sections. So this is really important and almost worth memorizing of what are the 6 main chapters. So they have a definition and overview. Then they have a chapter about diagnosis. When you're first seeing a patient, what should you be doing? What testing should you be doing? What history and physical? Then they have a big review of all the evidence that supports preventive and maintenance therapy, all the different things we do. So this is really kind of a review of evidence chapter. Then they have a chapter on management of stable COPD and a management of unstable COPD, exacerbations. And then finally, they talk about COPD and comorbidities. And that's really important because there's a lot of evidence that effective management of people with COPD means managing not just their COPD, but also their diabetes and their chronic heart failure and their hypertension and their coronary artery disease and their peripheral artery disease and their rheumatoid arthritis and their depression. That you can't manage as a care provider. You can't just take care of one disease at a time. And many of you know that choices of medicine in COPD and in other diseases partly depends on awareness of what other problems the person has. So keep this in mind. These are the categories they set up. And when you think about it, you know, chapter 2, chapter 4, and chapter 5 are what we spend our days pretty much doing, diagnosing initially and doing the basic workup, then taking care of the stable COPD, and then when things kind of get out of hand, exacerbations, taking care of that. Next slide. So what's new in 2021? Well, the big thing that's new is they did a whole new chapter related to COVID-19, and we'll come back to that. That chapter has 22 pages and 172 references. And as you all know, there's been an explosion of literature and publication about COVID-19 over the past year. If you haven't taken advantage of it, West Virginia Echo has a weekly COVID-19 echo session, which has been a great source of information for people all year. The COVID-19 chapter 7, I said it has 172 references. Overall, one of the things that GOLD does each year, that their committee does and their staff does, is to review all the articles that have been published in the world about COPD in the past year, and then they apply quality measures and they filter those and they pick what they think are the best things that merit being added to this report, and looking to see whether new things have come out that require changes in this report. So for this year, an example of how that works is this year, they added 244 new references. Now, they probably looked at 600 publications, because there's tons of literature out there, way more than anyone can possibly look at. So they could have looked at 600 or 500. Of those, 244 met their criteria for validity and quality, and they added those to the report. And so it just so happens, so if you think, well, 172 of those were for the new COVID-19 chapter, that means that about 72 others besides that chapter made it into the report as relevant and valid. Next slide. So I said that there is a teaching slide set of 52 slides. If you look, it's actually got about 56, but several of them for some reason are duplicates. So we'll call it 52 slides. And what I did was to go through so this year, my big read, besides chapter 7, was to go through these teaching slides and look and see, were there ones that I wanted to use here that I thought were really important to share with you. So this is going to kind of be our overview of what's actually in COVID 2020 run report. And everything here was the same last year. Nothing here has changed. And most of these slides are reproductions of figures or tables that are in the actual GOLD report. So I got 10 slides. Here we go. Go ahead. This is one that I always keep coming back to. And if you look at these slides or at the actual figure, in the lower left corner there, you see figure 2.4. So remember, chapter 2 of the GOLD report is diagnosis and initial assessment. So this comes out of the diagnosis and initial assessment table. And we have printed this out and posted it on the bulletin board of the wall in our breathing center. And our team has made it a habit when we have a new patient of actually in their record putting what their GOLD grade and group is. In articles and presentations, you'll frequently see people talking about the GOLD stage of a patient. Well, they're talking about that ABCD table there. The official orthodox way to do this is to, using this figure, is to assign the person a group, and that, or I'm sorry, a grade. And the grade is simply what is their obstruction severity in terms of their FEV1% predicted. And it's and what GOLD uses, which is a little different from American Thoracic Society, what GOLD uses are these 4 categories. And if you just memorize 80, 50, 30, you'll be able to put them in here. It's a measure of a severity of their obstruction. So that's their grade. And then the little ABCD table is a measure of their symptom severity. And you can see that if you have COPD, the best group to be in is A, and the worst group to be in is D. And whether you're in A or D depends on how many exacerbations you're having a year, and also what is your symptom severity, either in terms of MMRC or CAT. And since we're doing pulmonary rehab, we're routinely doing CAT. So we actually usually have a CAT. So I would encourage you, print this out, put it on the wall, make it a habit as a team of saying, what's this person's GOLD grade and group? because the group both relates to prognosis and it relates to a slide you're going to see a little later on, which is how you assign initial therapy, bronchodilator therapy, for your new patient. Next slide. Okay, now we're not going to read all this, but this slide and the next slide are a really great evidence review, and you can see that they have ranking of evidence, and all evidence-based guidelines do that, where evidence A means that's the strongest evidence we have. And then there's B, and then there's C, and then there's D. And evidence D is kind of like Dr. Doyle says so. Evidence D is just expert opinion. That's the lowest evidence. The best evidence, evidence A, usually comes from good meta-analyses or systematic reviews, groups of randomized controlled trials, and so forth. But when I look at this, I think one of the main things I picked out was the 1, 2, 3, 4, 5, fifth bullet down, which says LAMAs have a greater effect on exacerbation reduction compared with LABAs and decrease hospitalization. So LABAs, the bullet before says LABA and LAMAs both significantly improve lung function, dyspnea, health status, and reduce exacerbation rates. But then it says LAMAs have a greater effect and they decrease hospitalization as well as exacerbations. And one of my takeaways this year and last year is that I think we should be using LAMA and LABA combinations more than we do. Seems like every primary care provider is throwing people onto Symbicort or a LABA ICS inhaler, but I see very little use relatively of the LAMA-LABA combinations. Maybe that's because they're so expensive. I'm not sure. Next slide. They have a similar summary of anti-inflammatory therapy in stable COPD, which mainly is using inhaled corticosteroids. Although you can see they have PDE4 inhibitors. That's roflumilast. Remind me the brand name. Roflumilast is Aranesp. No, not Aranesp. Roflumilast. Okay, if you think of it, throw it out. But anyway, roflumilast is a PDE4 inhibitor that reduces exacerbations in people with severe COPD. We use it very little. Pulmonologists tend to use it a lot. Would you go back to the previous slide, please?
Dr. Doyle, I apologize. Was it one slide back you needed?
Yeah, one back. Ooh, keep going back. There you go. So this is really, think of this as a summary slide for primarily for choosing and using inhaled corticosteroids. Next slide. This is a little bit out of order, but this is a good time, but we can put it here anyway. There's going to be another slide after this about inhaled corticosteroids. And for those of you who joined recently, I didn't make these slides up. These are not original for me. These are slides taken from the teaching slide set of Gold 2020, which is available free at their website. So what this is talking about is that what we all know, how important it is to teach people to use their inhaler. And if you look at the second bullet, Lisa Emery, it says the choice of inhaler device has to be individually tailored, and it will depend on access, cost, prescriber, and most importantly, patient ability and preference. And I'm happy to announce that Lisa Emery has agreed to do an echo session this year. I believe it's the first Monday in October, on matching the inhaler to the patient. But she's always pointing out to me that it's really important to do exactly what they're saying here. And note, if you notice, this table, or this slide comes from chapter 3. That's the chapter that was reviewing evidence. Next slide. And then this is, again, this is emphasizing again, choice of inhaled corticosteroids. So for many years, there was concern in the asthma world that inhaled corticosteroids were being underutilized. And I think I don't know what the evidence is about how that's been overcome. Like we've had lots of quality measures that we've done in our practice over the years, mandated by the feds, that we're looking at whether people with moderate persistent asthma are on inhaled corticosteroids or not. That was a quality measure. So like many things, there's an underuse and there can be an overuse problem. My opinion, which is evidence D or worse, is that inhaled corticosteroids are overused. And that there's people that are COPD patients that get put on Symbicort and or one of the 4 or 5 other LABA ICS combinations, just because as the next thing to do after a albuterol inhaler. And we should really be looking at whether that's the best choice. Strong indications, as you can see here in the green column for using ICS, is that the person's been in the hospital with a COPD exacerbation, or they're having 2 or more exacerbations a year, or their blood eosinophil count is more than 300 cells per microliter. I think that's usually, you don't get that in a simple CBC. So what you have to do is you have to look at your CBC differential, see what percent are eosinophils, then multiply that, like if it's 4%, 0.04 times their white blood count, and that will give you their blood eosinophil count. So usually it's going to be something like if it's more than 3 or 4%, that's a reason to think about using ICS. And then another really good reason is if they have evidence of reversibility, a significant reversibility on their post-bronchodilator spirometry study. One of the reasons for being careful about this, if you look in the red column, is that inhaled corticosteroids are associated with increased pneumonia events in people with severe COPD. So that's a reason to use them thoughtfully and selectively, and not as your knee-jerk next inhaler in people who need more than an albuterol inhaler. Next slide. This is the slide in gold about pulmonary rehab. And it's slide 3.8, so it's in the evidence review. We all know this. We know it's being underutilized. Next slide. But the gold features it. Now, this is kind of the companion slide to the one I showed you at the very beginning. The very beginning was the refined ABCD assessment tool that I said you should print out and post on the wall of your pulmonary department and walk over there together and put your finger up and say, okay, this person is over on the right-hand side and in the top, and then put that in your note that their gold grade and group is 2C. So this kind of goes hand in hand, because what this does is it tailors their initial treatment to what their group is. Because I think it's so important, I'd encourage you to memorize where these are. When you go looking for them in the gold report, you have to scan through 150 pages to find them. The ABCD assessment tool is figure 2.4 in chapter 2. This one is figure 4.2, turned around. It's in chapter 4 on management of stable COPD. So that's an easy way to remember it. I consider this very important. There's a way more complicated slide that comes after this one that I did use last year. I didn't put it in my top 10 this year. And it tells you how to modify treatment when this first step doesn't work. So it's worth looking at. I decided not to throw it in. Next slide. This is a different initial pharmacologic treatment put together by the Primary Care Respiratory Society in the UK. And they did this based on, in 2019, comparing the NICE guidelines and the GOLD report and noticing that there were some differences and coming up with their own, what they call common sense approach for the primary care provider, which is called GP in the UK, where everybody in the country has affordable health care without losing it when they lose their job, or having to change it when they move from one job to another. And so in the UK, this is what they came up with and recommended. And you can see at the top there, the blue line, they stress non-pharmacologic thing, and then they separate people into 3 categories: COPD with predominantly shortness of breath, COPD where the problem is more exacerbations, and COPD with asthma. And I think asthma means that there's significant reversibility on their post-bronchodilator study. And you can see that's where they use ICS. That's the only category where they're using LABA ICS. The other two, when you don't have that asthma reversibility category, they're recommending LAMA-LABA plus SABA, or a SABA with LABA or LAMA. And then moving on down, they, in that far left column, then they would, if that didn't work, they would go ahead and switch from, or upgrade to the LAMA-LABA. And then all the way down at the bottom, because this was done in 2019, they have triple therapy. So I think they probably published it about the time that Prevalence G first came out. Next slide.
Dr. Doyle, it was going a little bit in and out there with the audio.
All right, thank you. This slide is about interventional bronchoscopic and surgical treatments for COPD, which was very well covered by Dr. Zulfikar in our last echo. So this is kind of the gold slide that summarizes all the things Dr. Zulfikar was telling us about. And mainly what we're hearing here from our patients is lung reduction surgery, and that's called LVRS here, lung volume reduction surgery. And then we're definitely hearing about what's called, let's see, BLVRI, bronchoscopic lung volume reduction, which is the little one-way valves that are being put into being put into bronchi. And in our state, they're doing that a fair amount at Cabell Huntington, and I don't remember if WVU has started doing that or not, but they probably will soon if they haven't. As of last year, I think they weren't. If anybody, David, or if anybody else wants to speak up about that, go ahead. We're almost done here. Next slide. I think this is the last one. Yeah, this is a really important one, and it's one that we have kind of evolved for ourselves over the years here, because as respiratory therapists and primary care providers, all the time we're having patients come in who are our COPD patients, or they're calling us up who are doing worse. And there is a tendency for us to say, oh, Mr. Jones is having an exacerbation. Let's call in corticosteroids and Zithromax for him. And it's always important to give pause and to say, okay, yeah, what else could it be? So this is the what else could it be slide, which more than 20 years ago, we already had this on our wall here to try to think about. Brenda Marion and I, who is our nurse coordinator all the time, would be going through this. So when you have somebody whose breathing is worse, and they're not following their usual pattern of exacerbation, are you really kind of worried about how they sound over the phone? Think about pneumonia. I mean, that is an exacerbation, but it's a more severe exacerbation. In the past year, frequently it's been a coronavirus lower respiratory infection. Think about pneumonia. Think about pneumothorax, and you can rule that in or rule that out right now with a chest X-ray at your facility usually. And for Cabin Creek, that's something that we can now do. And is that Carl over there? All right. Hey, Carl. Think about pleural effusion. That's another thing a chest X-ray can show you. Think about pulmonary embolism. And in the primary care setting, you can do a blood D-dimer test. And if that D-dimer test is negative, it has sufficient sensitivity to rule out PE pretty well. Positive, then you're going to have to send the person for a chest CT. Chest CT. How's this? Okay. Chest CT doesn't have to be the first step. I mean, yeah. And then think about pulmonary edema, which is basically saying exacerbation of chronic heart failure or initial onset of chronic heart failure. And then cardiac arrhythmias, and we can test this by a radial pulse, an apical pulse, and an EKG. So 1, 2, 3, 4, 5, 6 things to consider. And one other one that we had on our list was CO2 retention if they were using too much oxygen. No, from CO2 retention. Next slide. Go ahead.
Yeah. Okay. Hey, Dan, turn off your personal video. We're not getting your audio well enough. Just turn off your own camera so we can hear you better.
All right. How's that? Any better?
Seems better so far.
Okay. Here's what's in. So Wave, Petra, and all else fails, I'll let you guys just go to a conversation among yourselves. So here's the new chapter, chapter 7 on COVID. And I just summarized here what were some of the main takeaways I got from that chapter. They said to temporarily suspend PFT and pulmonary rehab during community surges. Well, we all did that. They interestingly said there's no increased risk of coronavirus with COPD. So having COPD doesn't itself put you at increased risk for COVID. But if you get COVID, you're at increased risk of hospitalization. They said, remember that there is co-infection with other respiratory pathogens. So, and I struggle with this sometimes. Well, if they have influenza, then they don't have coronavirus. Not true. You can have co-infections. They said there's no reason why you need to change any of their COPD medicines with coronavirus infection. So ICS, LAMA, LABA, all okay to continue. When they have coronavirus, you treat them the same as you would any other COVID-19 patient. And they have a nice figure that I'm going to show you in a second. And then finally, they have a really nice section on telehealth with a really good checklist and template for performing and documenting a COPD follow-up visit. So those are my main points. This is their figure 7.1 is kind of a treatment overview for COVID-19 in COPD, and they actually reprinted this from an ATS article. So this is actually an ATS, American Thoracic Society figure that Gold grabbed and put into their report. And if you look and see that when it's mild, what you do is you keep treating them with their regular medicines and do exactly what you would do if they had an exacerbation, probably pulse of steroids and antibiotics. If it's worse, then that's when you add special coronavirus treatments like systemic steroids, remdesivir, anticoagulation, and then the next group are in the hospital. Next slide. Okay, if we do just go back one slide, please, Petra. Yeah, just stay there for a second. And I just jumped out, it's 8:40. So we do have a case presentation, but I wanna stop. And if we don't get to that case, it's even okay. But I wanna stop and give people a chance to ask questions or comment about what they've seen here or things that you notice might have been left out.
Thank you so much, Dr. Doyle. And we also encourage everyone to chat in as well if you're having audio issues.
Okay.
Any comments, questions, thoughts anyone would like to share with the group or ask Dr. Doyle?
Be patient. Be patient, Mitra. Somebody will jump in. Come on, you guys. I didn't mention non-invasive ventilation. Is that okay?
Well, I'll ask a different question. The whole Lama Laba Saba story that you were trying to tell has been around for a couple of years. My limited experience is that there's tremendous resistance from the patient to paying for it because it's none of them that are affordable. because they're almost all still trade. And, I don't know how to get around. Do you have a good way to get around that? Because those medications are exceptionally expensive.
Lisa Emery, so you guys can't see me, but I can see you. Can you hear me right now? Okay. So Lisa Emery's shaking her head yes over there. No, I don't think I do have a good answer. I mean, 340B pharmacy, 340B pricing in pharmacies is a partial answer. I haven't found the, whatever they call those patient assistance programs to be much of an answer, because it just shifts the cost to us by all the time of helping with paperwork. So Carl, I really, and Brandy reinforced, 340B pharmacies are helpful with cheaper prices. By the way, the Pharmaceutical Manufacturers Association of America is lobbying Congress tooth and nail to get rid of 340B pharmacies for hospitals and health centers. So they're working hard to take that away.
Dr. Doyle?
Yeah.
So we run into that too here at Dawes. What we have found is to, I'm sure everybody's doing the same thing, but keep absolutely in contact with your patients to ask them, how are they doing with their inhalers and so forth, because they'll tell us right up that, well, I can't afford it, or I didn't get it this month. And so we had a patient recently that she was not signed up on our pharmacy. We didn't know that. We try to catch everybody that comes in. So she went from, she was at CVS and hers were $75 to $100 a month for co-pays. And she came here and it was less than half. So she could afford to restart her treatment. So definitely utilizing it, making sure they're if you're on a clinic, on the slide, and then trying to just keep constant communication, with ones if they're in the program, whatever it is, to say, how are you doing this month? Because they'll tell us, I can't use it this month. And our pharmacies, what we found out too, is that maybe they're on this prescription, it's always $5. And then when we get charged more as a clinic for it, it jumps up to $50 or $60 the next month. So sometimes it's a constant flux on them. It's not fair to them, but at least if we know, we can try them on something else that's a lot cheaper and gets them to continue.
Any other approaches or experiences with getting people on their Anoro-Ellipta, or one? By the way, what the brands are of Lama Laba are Duaclear, Pressair, Udibron, Bevespi, Stiolto, and Anoro-Ellipta. Those are products. And so, yeah, it could be that one is affordable. It's like what we've struggled with over the years with the omeprazole, pantoprazole type drugs. I mean, 1 month Medicaid, it's affordable. One drug is affordable, and then a few months later they got a different one, which is the one that they're paying for. And so you really do have to. It's shape shifting all the time. Which one is the least least exorbitant? So Carl, I don't have a good answer. I'm sorry. I mean, partly, hopefully, one of these will go off patent pretty soon. But right now, that's a real problem. Well, any other? I guess a question would be for us. And I think that might be why we see a lot of LABA ICS, because I think those can be exorbitant also. And I don't think there's a generic LABA ICS yet. Does anybody know different? In other words, I'm talking about Advair, Symbicort, Dulera, that group. And the other thing is they're kind of all Me Too drugs. If we could have one good LABA ICS and one good LAMA LABA, I mean, of course, our country could afford it. It's just the way things are structured against the law to have affordable generic medicines because they're protected by patent. But that'll be the solution, I think, is when one of them goes off patent. It takes 17 years. All right, well, I'd like to go ahead and jump into the case then. So if you can come back to the slides. And it's the one
Dr. Doyle, was it the Excel document worksheet, or do you want me to pull up your PowerPoint again?
PowerPoint. It's in the PowerPoint.
Excellent. Is everyone able to see that?
After the next one. Okay, so this is a case not about a patient, but about a rural health network. And Johnny and Brandy and Lisa and Mr. Gunter and Tara, you know, you guys could close your eyes and listen to this. In a way, this is your case. The case.
Dr. Doyle, it's kind of cutting out there.
Okay, then read it. I'll stop talking for 1 minute. All right. Remind me to never come to an echo again without my earphones and mic. It seems like it makes a big difference. Next, so this rural network is us. This case is about us. And as I said, we've been around since 2013. We've provided, we have provided pulmonary rehab to over 800 patients. Next slide. What this slide shows is what is the prevalence of COPD in the populations we take care of. In the United States, and you've heard the left-hand column numbers before, that 6.9%, and David, if you're still here, if I have my epidemiology wrong, speak up, but I think the 6.9% for the US is 18 and over. So in other words, adults. So 6.9% of adults in the US have been diagnosed with COPD. In West Virginia, which competes with Kentucky for the greatest prevalence of COPD in the country, the figure is 13.6%. And in a number of our southern counties, it's even higher than that. CAMC has a ACO where they're tracking with about 30 different practices and hospitals with them. They've got a population of 165,000 patients in their ACO. They've identified 19,000 or 11.5% of them, but I think their 165 includes children as well. That might be why that's lower. Of those 19,000 people, they found that only 24% can they find a PFT. So the point of this slide is to know the prevalence of COPD in our population. It's around 12 to 13%, and to know that many, many people, you cannot find that they've ever had a PFT. And we looked at this specifically at Dawes and Luann, and Lauren Lucas have really helped with this week. And they told us that only 27% of our patients had had a PFT. We then went through 100 records, and we found that another 75% really had a PFT. It's just that the computer couldn't find it. And so what we know is that actually for us, it's around 47%. That's a lot better than 25%, but it still means that under 50% of our patients, even after exhaustive searching of the medical record, can we find they've ever had a PFT. Next slide. This slide shows what this network is doing in terms of providing pulmonary rehab and pulmonary function testing. And the fact is that if you take all our efforts to get put together, we're really doing a lot. And we have capacity to do more. And you all have seen this because this is the slide we put together at our RT quarterly meeting on April 16th. Next slide. So the big question is, how well do we do at applying the GOLD guidelines in primary care? And some of us are actually based within primary care centers, and more of us are in critical access rural hospitals that actually have primary care clinics attached to our hospital. So we, and I'm an honorary respiratory therapist, we as respiratory therapists have a big role in educating and influencing and encouraging the primary care providers we work with. Up at Roan Memorial Hospital, they now have pulmonologists coming there once a week. And their pulmonologists are doing pulmonary function tests on everybody, so much so that they have respiratory therapists coming in on Sunday to do pulmonary function tests, so that when the pulmonologists come in and demands, where's my PFT, they'll have it for the clinic that week. But primary care still isn't doing quite as well. We're at less than 50%. So if you think about it, these would be key measures to look at to measure our progress as a network in expanding implementation of GOLD guidelines in our settings. What percent of our patients can we document have had a PFT? What percent of our COPD diagnosed patients have been referred for pulmonary rehab? Can we find that in the record that they've been referred? Of the ones who've been referred, what percent complete an intake? And finally, almost to go back to my first slide, is the GOLD grade and group, which is that figure 2.4, chapter 2 in the GOLD guideline report. Are we getting our providers to routinely look at that and use it as the basis for treatment? So what I would like to propose to us as a network is to do a little audit once a year, or to do a chart review once a year. And so what I've done is I've given you a form that you can use, and I'll email this to you. Next slide. This is the last slide. So here's a GOLD chart review form. And what you would do if you wanted to do this, and if we did this, we could pool our results and get a network-wide snapshot maybe once a year. You put the medical record number, and so you find, is there a slide after this? Yeah, go ahead with that. I think it has patient selection, I think. Yeah, so the way you would do this, first of all, don't do it without getting approval of your medical director, because you shouldn't be in anybody's record without a need to know. And then pick like 10 patients. And my suggestion for picking your patients would be that they have COPD on their problem list, that they have one or more inhalers on their med list, that they're 50 years or older, and pick people you don't know. Because if you know them, that's great. They're already involved with you. I'm worried about the other 80% of the patients in your practice who've never gotten in contact with a respiratory therapist for a PFT or for being referred for pulmonary rehab. So then go back to the previous slide. So then I would just put their age, their gender, their last spirometry, the year of their last spirometry. And of course, if they've never had it, you just leave that blank. The next one, spirometry verified. What that means is, has their diagnosis of COPD ever been verified by having a spirometry? Both the GOLD report and the ICE guideline require spirometry for diagnosis of COPD, but hundreds of patients are grandfathered in with never having had that. Next slide, or the next column would be, can you tell from their chart that their GOLD grade and group has been assigned? Are they on inhaled steroids? Can you see in the record that they've ever been offered pulmonary rehab? What's the date of their pulmonary rehab intake? And I think it's high probability that you can find 10 patients that have never been offered pulmonary rehab. And then finally, when was their last flu vax and when was their last pneumovax? So I would love it, and we'll send this out to you. I would love it if you would do this and then send it in to me and Lisa Emery, and we'll gather them and tabulate them. And when you send them in, if you do, cut off the medical record number and just send us the rest of the chart and be sure to put the, and we'll identify it came from you, Brandy or Johnny or Tara or Luann. And we'll put it all together and we'll get an overview of the network. So that is the end of the case. I'm sorry I've used up all the time and that the audio was patchy.
No worries at all, Dr. Doyle. We really, really appreciate your time and going through that. It's always so nice having an updated version of this. So truly appreciate it. And like you said, I'll be sure to attach it in the recap email so everyone can refer to that chart you sent in as well. So did anyone have any questions or comments for Dr. Doyle? Dr. Doyle, I'm going to be patient.
What? Oh, good. Me too. Oh, except thank you, David, for that validation.
The workplace statistics are all 18 and over, just like you said.
Great.
And Dr. Doyle, were there any other final comments or anything you wanted to share with the group?
No, I think I've already given you an overdose.
That was awesome. Thank you so much. We truly appreciate it. And I do have that Excel document as well still. So I'll message you after this on whether we'll keep that for next time or something. But all right, everyone. Well, the only announcement that I have is that our next session will be on May 17th, and Dr. Silo will be discussing PFT interpretation. So keep an eye out for that reminder, and we'll see you all next time. Thank you, guys.